Thank you everyone for coming and taking an hour away from your lunch or having lunch in here. Just yes, enjoy it. Wonderful. I'm really honored to be here today and present you the research I've been doing over the past 6 years in the realm of trauma resuscitation and general emergency medicine. So today I will basically give you an overview of some of the studies that I've been doing and some of the results I've been obtaining throughout these research projects. So why don't we just start moving? Okay, I'll start just using this one. So Mark already did a great job about introducing me, so I'm just not going to repeat a lot of things, but I just wanted to tell you a little bit about my background. So I studied information science at Rutgers University, but what really started interesting me very early in my PhD was the focus on areas where we study how people interact with machines, with systems, with computers. So these areas such as computer-supported collaborative work, human-computer interactions, and the opportunity that I had at that time to join a team of researchers from Rutgers and Robert Wood Johnson University Hospital at New Brunswick, New Jersey, gave me this opportunity to actually start looking into trauma resuscitation and emergency medicine. So my focus is really on medical informatics and these complex safety critical systems such as trauma resuscitation, but from this HCI, CSCW sort of perspective. And the mission I sort of have for my overall research is really to build information technology solutions that fully support the social world. And if anyone knows this better, it's really you, medical professionals, who are sort of forced to use a lot of these information technologies and not always respond to your needs, they're not always friendly and not always listen to what you want them to do, right? So they don't really, and don't often support what you really need to do. So that was really kind of like a mission that I set up for the research and for the final ultimate goal of what I've been doing. And how do I do my research? It's really qualitative, mostly qualitative. I apply ethnographic techniques to studying different domains, in particular trauma resuscitation. So I like to immerse myself in the environment. I like to become one of you, wear a white coat, wear a badge, be a fly on the wall, observe what you do and how you talk to each other, how you interact. So I use techniques such as participant observation, field work in general. I also use some classic techniques like interviews and focus groups and surveys, questionnaires. But also very helpful here is, because a lot of places where I studied trauma resuscitation do live video recording of live events, so really complementing the analysis that I do through field work with these microanalysis of interactions through video is really helpful, is really helping this discovery process that helps in turn characterizing the processes that are happening during resuscitations. So some of the studies that I've done to date, or features that I looked at in trauma resuscitation are what information needs people have during the process, how they share information and communicate with each other, what decisions they make, what are the major decision-making tasks, how is the work coordinated, is it successful, what are the inefficiencies. I was also interested in leadership, especially leadership structures, because trauma resuscitations are interdisciplinary teams, and it's really interesting to me to see how this interdisciplinarity plays out in such a highly dynamic environment. I also looked at team errors. We know quite a bit about individual errors, or where we err as individuals, but it was interesting, and trauma resuscitation enabled this view of team errors because I look at the process as a teamwork. And then I looked at a little bit of documentation and workload. But in the interest of time, today I really wanted to highlight a few things from a couple of studies and where we see information technology really helping improve some of the processes in trauma resuscitation and generally emergency medicine. But before I go more into detail about these studies, just a little bit about the main descriptions, because I'm not sure how many of you here are actually involved in trauma resuscitation and how many of you have been or seen the process, but just to give you a little bit about the main description. So the main goals of trauma resuscitation are really to identify the life-threatening injuries of the patient, stabilize the patient, and then develop a plan for hospitalization. It's a really highly dynamic process under time pressure, And it's not a free-form activity though. Trauma teams follow a standard protocol called Advanced Trauma Life Support that provides this standardized approach to treating patients, trauma patients. So it consists of two parts. The first part is a primary survey, which is basically a quick examination of major physiological systems such as airway, breathing, circulation, and then they also look at neurological exam and expose the patient to look at the injuries on the back. And then the second part is the more detailed injuries, where we look at other injuries that patient might have sustained in the accident. So when does ATLS impact mortality? Most patients die within the first hour if it's a critical accident, but those who live more than an hour, what has been found in research that ATLS really helps within that first hour after the patient's arrival to the trauma bay or emergency department. And it does reduce overall mortality, and its effectiveness is most evident among severely injured patients. But yet, what we see in research and reviews of trauma resuscitations is that 16% of deaths at level 1 trauma centers are preventable, and 1/3 of these preventable deaths are due to inappropriate application of this procedure of ATLS. And these preventable deaths are related to errors in ATLS that occur basically in all phases. And what are some of these errors? On average, people have been finding between 6 to 12 errors, and basically non-resuscitation has been found to be error-free. And in pediatric studies specifically, most common errors were found to be dosing errors, like administering fluids and medications, but then also we've seen delayed administration of oxygen, neck wasn't stabilized, and other kinds of errors that people commit. So what are the factors that are contributing to these errors? We split them basically in 3 categories: patient factors, providers factors, and systems factors. Patients, right, they are unstable, their status fluctuates throughout the process. With providers, we know that even though they're skilled and have a lot of experience and knowledge, they might be fatigued, there are a lot of distractions throughout the process. But then there are these systems factors. We have these transfers of care between different teams along the patient hospitalization path. We have dynamic flow of participants in the trauma bay, right? People are coming in and out of the trauma bay as they are being needed or called to take care of the patient. So this fluctuation of team membership and also hierarchical team structure. So it really, I think, where the technology can help the most is really addressing some of these system factors. And let me tell you a little bit about what actually here can sort of a domain or an avenue for information technology application. So trauma teams are hierarchically structured teams, and roles and responsibilities of each member are clearly defined. So, for example, we have a team leader who coordinates the care, assigns tasks, and this is usually a senior surgical resident, or an ER physician, or an attending surgeon. We then, for example, have a technician who sets up the equipment, connects the patient to the monitor, takes vital signs. Then, for example, we have the scribe nurse who documents the event. Everything that happens throughout the resuscitation is carefully documented for both archival purposes and retroactive evaluation of the event. Another interesting feature is the team positioning. And this has been pretty standardized across trauma centers, though there are some variations, but basically what we are seeing is that people who are in charge of managing airway are usually at the head of the bed, and then leadership roles are positioned at the foot of the bed, and then we have nurses and technicians along the side of the bed who are taking care of the patient. So really the successful coordination and successful trauma resuscitation does depend a lot on these teamwork features that are happening throughout the process. And awareness of what is happening in the room is extremely important. It is important to know not just information about the patient, but also what other people are doing in the room, because it's such a team-dependent process and there's so many people involved in the care. So just in summary, this introductory part, so we see that ATLS is an effective strategy for improving outcome after injury, but although effective, it may be ineffectively applied, contributing to preventable deaths after injury, and errors are common during trauma resuscitation may be caused by a range of contributing factors. So the research question I've been asking over these past couple of years is, can really information technology help in this situation, and can we reduce errors and improve efficiency during this process? And what really struck me as I was starting this research, and this is the Trauma Bay at Robert Wood Johnson University Hospital when I started my PhD in 2006, what really struck me here is that this is a really tightly packed capacity room with all sorts of equipment. It's the best equipped room in the hospital. It has all this instrumentation, necessary equipment for treating patients, but surprisingly, there isn't really any information technology in the room that helps people accrue information about the patient, integrate this information, and allow easier access to patient information. And then, again, even after a couple of years, Robert Wood Johnson remodeled their trauma base. So this is a picture from 2010. It's a really nice, spacious, big room, very modern looking, and we see a lot of the equipment and instrumentation in there. But besides the vital signs monitor and maybe a few like digital clocks and pieces like that, we don't really see, again, any information technology, right? It helps people access information about the patient and team activities faster. And then here is an image of the top trauma center in the country, which is Shock Trauma Center, University of Maryland Medical Center in Baltimore. And again, Trauma Bay, as we know it, a lot of equipment, but not, surprisingly, not so much information technology in there. And then finally, here is the image of Children's National Medical Center, which was another site where I did a lot of the studies, and where I focused on pediatric trauma resuscitation. And again, a very nice, big room, spacious, modern, equipped, well-equipped, but besides that vital signs monitor, we don't really see any other information technology pieces in there. Though there is some progress, and this really came as a result of some of the collaborations we had with trauma surgeons and teams at Children's in Washington, D.C. And what you see here are the latest additions to the Trauma Bay, these large screen monitors that were put into the room to basically augment vital signs monitor. So there isn't any other information displayed there except the vital signs monitor that are just now visible to everybody in the room, regardless of where your position is. If you're at the foot of the bed or the head of the bed, because they are on both sides, opposite walls to each other, so everybody in the room can see them. So basically, you just have this augmented view, huge view of vital signs monitors. But is there anything else that we can display there? Maybe we can display some other information there. We are seeing these monitors increasingly appearing in almost every part of the medical facility, in hospitals, in patient rooms, in nursing stations, in hospital wards. So why not in trauma as well, right? Maybe we can use these monitors and this technology to really display some of the information that could potentially improve the process. And here is finally Trauma Bay here, a shop that I took a picture when I visited the center back in January, and I really like this room. First of all, I think it's really smartly designed with the X-ray scanner actually suspended from the wall, and it really enables, I think, really fast treatment and intervention in terms of X-ray images. But again, I was just seeing a lot of similar things and positioning the equipment as in other trauma bays and not so much information technology. But I'm not the only one who's thinking about this, right? And there's a lot of research going on in this direction. And what you see here is the trauma bay of the future, and it's actually a real vision that is being executed right now by the Pentagon. And this is going to be remodeled trauma center at Shock Trauma Center in Baltimore. It's going to cost about $160 million. It's going to open in 2013. So what you see here, right, is exactly what I was telling you. It's a lot of these displays around this patient bed. It looks very modern, very high-tech. But my view here is really that, yes, it's lovely. It's great to have all this technology inside. But before we start putting these screens and all this technology, we really have to understand how these teams work together, where inefficiencies are, where errors are. so that we know what information to display, how to display, not just put something forward without really talking first and understanding the process and talking to medical professionals. So that's where my research is focused on, really on understanding nitty-gritty details about trauma teamwork, and then exploring these possibilities for future design and development of technological support. So let me start going through some of these studies and giving you some highlights about certain features that I looked at. So I'll start with work coordination. And what really became clear after studying trauma for so long is that successful work coordination requires awareness of what is happening in the room, which also means knowing who is in the room and who has what role, because it's such a because of the labor division of labor. And different team members having different tasks, and then also knowing one another's expertise, because it's really important to know if I have an anesthesia resident, can that resident intubate a patient? Is that a senior or junior resident, right? So because there are some unique features of trauma teamwork compared to some other high critical and safety critical settings, we know that most trauma team members are not dedicated only to trauma care. They have their other duties during the day. They care patients, they do surgeries, they consult. So they're not really there all the time. And they also come from different disciplines. And these two features really result in people in the room, same room, not necessarily knowing each other. So we can have basically two trauma resuscitations back to back, but be completely different or slightly different team members depending on schedules, annotations, and other social factors in the hospital. Now, what this brings up two problems. First, people have difficulty in identifying roles, which in turn makes it difficult to communicate information to those who need it. And as a team leader, you need to assign a task to certain people to execute those tasks, but if you're not aware who is who in the room, it can be difficult. And there are clues and mechanisms to determine who is who in the room that are currently being used. Like one of them is positioning around the patient stretcher, and even though this positioning is standardized pretty much, but during the process it frequently reconfigures because people simply move around to fetch equipment, to get around the patient. So that clue may not be reliable all the time. And another one is color or scrubs. So what I've seen at some centers, people have different, depending on their role, they have different color of their scrubs. So for example, surgeons have green scrubs, technicians dark blue, nurses light blue. But again, some centers it's either all green or dark blue or light blue, and then on top of that people put these gowns, protective gowns that could be in uniform color, so this again prevents people from using this glue as an efficient mechanism. And then the second problem that also makes work coordination quite inefficient oftentimes is overcrowded trauma rooms. And this is especially evident in cases with severely injured patients or traumas that come without prior announcements that are at some places called like Trauma Now. So what we saw when we looked at the videos of 243 consecutive resuscitations, and we recorded a large number of data points. One of them was team members and who is present in the team. So what we found out, so first this is the recommended suggested team size for different activation levels. So when you have a transfer, the recommended size is 8 members of the team, and then the highest level of activation is attending trauma, where recommended size is about 14 people. But what our video review revealed is that, actually a number of people doubles from the suggested size. And especially in high severity cases when it's really, this coordination is really most efficient, most needed, right? And then we see this number of people just shoots high, extremely high, because we have onlookers, right? But then people also want to just come in and help, and they have free hands. Why not just jump in and see if they can somehow help? So this number of people really, although it's nice to see people want to come in and respond and be helpful, but on the other side, they don't realize that this is also making the process inefficient because of such a huge number of people in the room. And in one resuscitation, I think we visited like 47 people, which was just amazing, given the size of the rooms, which are often not so big. So what happened, what Chief of Trauma at Children's decided is to try these role tags as a mechanism to potentially reduce the number of people in the room, but also improve coordination so that people can know who is who in the room. So these role tags are a very simple solution, wearable self-adhesive paper tags that indicate members' role, and people just grab them from a little bin and put them on the chest so that they're clearly shown. And what we found after observing for about 6 months, I spent 6 months at Children's observing the use of these role tags and how they impacted the trauma process. And unfortunately, the results weren't so encouraging. So these role tags, although they were working quite well in resuscitations where everything is calm, you have a stable patient, not many people, everybody's talking nicely, calmly, slowly. But then when the coordination is most crucial in highly severely injured patients, they didn't work. They didn't work because people simply didn't have role tags, because the last thing they wanted to think about when they were rushing to the room to take care of the patient was grabbing that role tag from the bin. And also the overcrowding issue wasn't prevented because the number of people in the room simply just kept increasing and wasn't really helped by this low tag solution. But another interesting phenomenon that I observed here is that this role tags practice really created some unintended uses and meanings for the role tags. What I saw is that because role tags were really meant to limit the number of people in the room, so they were really limited only to the core members of the team, those who were not supposed to be in the room but still wanting to learn felt slighted. So they gamed the system so that they actually grabbed any tag they found, and then they strike through the name on the tag and wrote their own role. And here we see an ED resident who wanted to be in the room, right, to learn. It's on-the-job learning, but he's striking through the whatever tag he grabbed at that moment and writing ED resident. So it really, we saw that really these role tags became a symbol of status and belonging. And if you don't have a role tag, you cannot be in the room, and it felt wrong to some of these people, right? And then another interesting phenomenon that we observed that people were splitting role tags because sometimes more than one person responded to the call, and this especially was evident when somebody was oriented, like a junior starting nurse orienting for a position, and then instead of taking 2 tags because they were told only one person per role, right? So then these nurses would split the tags so that one has nurse, one has right, or whatever the role was. And so here what was interesting is these role tags also were a means of socializing and showing attachment. So here we see these nurses splitting the tag, but then after putting the tags, they sort of like lean onto each other, like, look, we are just wanting to sit. It was really, in addition to being a requirement, it was really often found to be just a means to find a little bit of relaxation and fun, and it was something like in such a stressful situation. So we saw the role tag as a low tag solution failed, but is there anything that information technology can do to help? Because in general, they are good things. People talked about it as a good thing because yes, I see this big giant sticker on somebody's chest and I can easily say who's anesthesia, who's respiratory, but because it didn't appear, they weren't appearing on people's chests during highly severe cases, they still wanted to see what could be done. So maybe some solutions, information technology solutions, could be potentially used here. For example, we can also use smart badge technology and smart clothing to maybe display more than just a role. Maybe we can display names of people so that people call each other by name, or a level of experience, expertise, and even responsibilities. And we often heard from anesthesia that are not so often part of the trauma team training, that when they come to the trauma resuscitation, they're often confused about what exactly their role is. They know they have to intubate, but how and when and how to interact with other team members. Then the biggest problem was how to sustain role tagging under time pressure. And again, because if we start using smart badges, role tagging could be done basically automatically because we know a priori what the schedules are, what the roles assignments are, so we could basically do this automatically. And then in terms of the overcrowded rooms, the best solutions that we came up with at this point really is to have these live video feeds for remote observers Because yes, everybody wants to be in the room and to watch and to observe and learn by watching, but because it does obstruct the process, maybe one of the solutions would be simply to have these live video feeds to have these people still informed about what's going on in the room. So let me jump quickly onto leadership here. And as I said at the beginning, leadership was really interesting to me as a feature of teamwork because it does really depends on how strong leadership is, how efficient the process is. So what I did here is that I used the data that I collected at both centers, Robert Wood Johnson and Children's. So basically what I had adult trauma center that is mostly governed and led by surgeons, but then also pediatric trauma resuscitations where we see this leadership shared between ED physicians, emergency medicine physicians, and surgeons. So this is the overview of the structures that I identified, and I'll go through each in a little more detail, but basically what I found is that so we have this interdisciplinary leadership and two structures emerged there, and then we have this cross-disciplinary leadership that has about 3 structures that emerged. So when we look at this sole decision-making that emerged in interdisciplinary, in adult trauma center, where we only have a surgical resident, senior surgical resident, without attending supervision, sole decision-making, he's the only one in the room who makes decision. What we really see that people clearly knew who is the leader, so there wasn't any confusion about the leadership. There wasn't any conflict in the leadership and in decisions because if I'm the only one who is making decisions, I don't conflict basically with anyone. But what we observed there that there were higher chances for unnecessary procedures because some of these senior surgical residents thought that it's better to pan scan the patient, it's better to do any procedure that seemed reasonable at that point of time without consulting with the senior attending. Maybe those weren't necessary. Then when we look at actually the case when we have a senior person, attending surgeon, supervising a surgical resident who is a team leader, we again see basically the best case here because we again have clear leadership. It's clearly who are the leaders in the trauma. We don't have so much conflict because these people are coming from the same discipline, they speak the same language, they come from the same background and have the same training. And then again, we are seeing now fewer unnecessary procedures because team leaders, surgical resident can always consult and talk about the interventions with his supervisor. But then when we move to shared decision making, where the decision making is shared with emergency medicine physician, here we see ambiguous leadership emerging because now people are confused in the room. Who do I listen to? Do I listen to my surgeon? So the surgical part of the team, wants to listen to the surgeon, but then the emergency room part of the team, nurses, technicians, they might want to actually listen more to an ED physician. So here we have some problems about deciding, okay, who do I listen to now for a decision or for tasks? And then, again, higher chances for conflict because we have now 2 disciplines basically trying to lead a process together. But again, fewer unnecessary procedure, which is important because ED physicians have more experience because they are in charge of the trauma center at Children's. They've been there for 20 years, 15 years, and then surgical residents who come there only on rotations, they don't really know so much about the process, about how things are done in this ED department. So the presence of an ED physician is extremely important because that's where we see a lot of these conflicts resolved about how do I scan the patient, what do I do? Do I need to intubate or insert a chest tube? And then this is the worst case scenario. This is where we see that these 2 people don't talk to each other at all. And this is where surgical resident is simply going his own route, and ED physician his own route, and leadership continues to be ambiguous. We don't actually have here conflict so much because these 2 people don't talk to each other, right? So there isn't really fewer chances for conflict. But then, again, higher chances for unnecessary procedures because, again, there is no conversation, there is no discussion. There are potentially possibilities for these higher chances of unnecessary procedures. And then we have collaborative. Finally, another good combination where we have surgical resident who is now supervised by both emergency medicine physician and an attending surgeon. And we saw this again being sort of like the best scenario in the shared decision making, where a little bit about ambiguous leadership being a bit ambiguous still continues, but not so much as in the previous cases, and then definitely fewer chances for conflict and fewer unnecessary procedures. So, is there anything that information technology could do here to help these people lead the trauma resuscitation better? And basically, really, it is about having access to information and retaining that information better. So it might be that different leadership structures require different kinds of information, but then how do we support it and how do we provide those kinds of information and resolve the conflict between the kinds of information that they need? But they would definitely all benefit from improved retention and access to patient information. So maybe some of those weakest aspects that we observed in each of the leadership structures could potentially be one of the goals of where information technology could help. And then I want to quickly go through team errors, yet another thing that I looked at in the trauma team work. And this was a big study. This was basically my dissertation research, and these were the final errors that I identified. We have interpretation errors that are due to sporadic, asynchronous data gathering. We have communication errors that are due to information loss. Management errors when team members lose track of the progress of multi-step procedures because there are so many of them during the process. And then we have these vigilance errors when team members fail to intercept and prevent errors of others. But I really wanted to focus only on one particular case here, which is interpretation errors, because I thought that would be the most interesting one to get this message about potential for information technology to help some of these processes and errors and inefficiencies that we are seeing. So here we have a case example, a patient that's injured in a motorcycle accident who sustained internal bleeding from a severe pelvic fracture that arrives to the trauma bay. After examining lung sounds and pulses, the team leader examined the patient's pupils and reported that they were unequal. Pupils dilated on the left, 4 on the right 2. So this was a sign, although weak, of possible internal bleeding, but nobody reacted. And the team leader immediately moved on to another evaluation step, inquiring, do we have x-rays here? Now, the orthopedic resident arrived late, just before the team was ready to take the x-rays. He performed pelvic rock in haste test for pelvic fractures, but didn't detect any injury. The orthopedic resident also failed to report any findings from his test. And what happened after several minutes, the patient collapsed, his blood pressure dropped to a critical value, and the team was not able to diagnose the cause of low blood pressure until the pelvic x-ray revealed that the patient had a bad pelvic fracture and a major internal bleeding. So what really happened here, and sort of this is a big conclusion that came out of examining a lot of these case examples, and here you just saw an example, is the team cognition. We have a team cognition system here that is functioning suboptimally, relying mostly on strong cues. So until they saw that x-rays, they really didn't suspect what was happening with the patient. They weren't really following some of those weak cues that they were seeing along the process. So we saw that these weak cues are often ignored, and then there's this reliance on others, of course, to acquire and validate observations, and when those others don't report findings or do it hastily or without or inappropriately, then it can be a problem. And then another problem is that these observations become available at different times, and often on the order of several minutes between different observations and exams. And then finally, these observations need to be memorized and recalled. And because we don't have that information, externalized information onto different artifacts that could be potentially used for retaining some of this information, we see that this impairs the quality of decision-making, leading to such interpretation errors. So what I'm really seeing in the process is that we have these many people around the patient collecting information about the patient, administering medications, fluid, reporting that verbally to the team, right? So the verbal communication is the major way of sharing information during the process. And then the team leader collects all this information, integrates, and then makes a decision based on information that he or she collected. So where I see really the potential of information technology is in externalizing those individual memories that people, and information that people keep in their memories. So instead of directly reporting, which still can be kept as a practice, but then also why don't we externalize that information that is being reported to some artifacts that can be then referred to easily and fast during the process. So we could have various types of displays that would externalize this information around the room, like the display you saw at Children's for vital signs monitors, but then we can maybe show some other information. And then maybe for less busy team members, we could have some interactive systems that could potentially help in capturing information and then retrieving information. Now, the challenge here is, of course, how do we capture information from the environment? Because there's so much information exchanged verbally throughout the process, and there is a problem now, how do we capture, how do we put that information onto those displays? So that one way to do that is through documentation, which was the reason why I was so attracted to studying this aspect of the teamwork, the trauma resuscitation. So what we have here, so I looked at the documentation process. I was looking into what are the limitations. So we have this scribe, nurse recorder, who documents everything that happens during the process. And she uses this beautiful big flow sheet, right? It has all the information about the patient. So I was interested first, what are the limitations of the process? And then what roles this nurse recorder has instead of just documenting information. And then based on that, what could be system requirements to support not only documentation, but also that capturing of information. So despite some challenges that we found, what was really interesting about this process and the flow sheet itself, that it does support teamwork to some extent, even though it's pen and paper. But right because it's pen and paper, it does allow nurse to navigate sections easily, to record information fast, even to quickly detect missing items, right? Because Flowsheet basically roughly follows that ATLS protocol that I explained at the very beginning. So by looking at the missing items on the flow sheet, the nurse can go back to the team and say, oh, well, you forgot to examine pupils, why don't you do that? Or, right, so she really then can serve that role as a reminder and put the team back into the on track and do the tasks that they were missing. So really the roles that emerged out of this study was that the scribe and the nurse recorder not only document information, but also monitors the team process and can serve as a reminder to the team when they forget or skip a task. She also regulates the environment. In a lot of those overcrowded situations, the nurse scribe was the one who was saying, okay, everybody, please calm down, let's move on. Those who are not needed in the room can please step out. So she's also regulating the environment, but also channeling information and actually serving as an information hub, because if somebody in the room needs to know what the patient weight is or how much fluid has been administered, they will go back to the nurse recorder and ask, okay, because you recorded it, you know how much fluid have we given so far? So we thought that really it's a great opportunity because we see this nurse recorder documenting already information from the environment, and that could be just a great proxy for collecting some of that information that we could then project on the monitor. So what we have here is a system that we developed. It's a really prototype at this point, TraumaPen. It uses the digital pen, so we are still preserving the way of working. Right? Nurses love pen and paper. They would never ever, they told us never ever give us tablets and iPads. I mean, they're wonderful, but just navigating that enormous flow sheet using iPad would be a really difficult task, right? So we're still giving them pens. They're a little bit fat, but not so much. I mean, it's the old way of working. And basically what we did with the flow sheet, we just made a few fields, the information on the fields that we thought would be important for team to see on the monitor, interactive. So when the nurse writes down the flow sheet or puts a mark, that information automatically transfers in real time on the display. And this is just the initial prototype. It's very initial, very rough draft of what the information could potentially be up there. So at the very top we see patient information, some of the graphics, and then in the middle part we see these basic steps, right, ATLS steps, and what findings have been, what exams have been done, and what findings are, and then the bottom part could be used for displaying vital signs, maybe have access to patient information. So we did initial evaluation of children's using some focus group simulations, and we deployed the system. And what we found, we basically talked to nurses who are the ones who will be responsible for documenting, so we really wanted to see to what extent will this added task of documentation for real-time presentation affect their current ways of working. But we also wanted to talk to team leaders to see, will this information that we project on the screen be useful, and will they actually use that for their real-time decision-making? So what we found from nurses is they really thought it was good that we preserve pen and paper because it does not change nurses' current way of working. They thought that graphical representation of primary survey steps was beneficial because it gives you that quick overview of these are the tasks I've done, these are the tasks I missed, so it was really neat, they thought. But then they also suggested a couple of additions and how we could potentially change some of the information. But then they also had a few concerns, and this was the first red flag about the system that was showing that there are some limitations in this idea. Because nurses often switch between documenting different data elements, right? They might keep the mechanism of injury and EMS report they receive at the beginning in their head while focusing on maybe exams from primary survey, and then once the situation slows down, then they go back to document some of those initial reports. So because of that switch, the real-time presentation that we imagined would work with this system is a little bit now questionable. And then also that middle part where we wanted to show the changes in the patient status as they are being found and reported also is problematic from this standpoint because they are recorded in free-form progress notes, and those are extremely difficult to detect and recognize right now with the technology we have. So because those notes also vary, it's another limitation. And then when we talked to a surgical resident and their physician, it was a slightly different impression. First of all, they thought that there's really no need for that graphical representation. Because the moment they enter the room and they see the patient, they can see that tube on the patient's face. They can see if the patient has an IV, right? So just seeing the drawing of the tube on a screen versus the patient's face is not necessarily different. So they rather wanted us to focus more on the patient information, demographics, and mechanism of injury, initial evaluation findings, because this information is something that everybody in the room wants to know and needs to know from the very beginning, and especially in trauma when people are coming in late. Those who are coming in late, they first go to the leader and ask, okay, what do we got? What's the story? What's the kid about, right? So they get distracted and interrupted by these questions from latecomers. So they thought if we had that information up on the monitor, some of those questions would simply go away. And then they also had some suggestions about how can we improve the display and what information can we put there. So yes, the digital pen was, we thought, a great idea, people liked it, but we have this problem because we are seeing the disconnect between real-time documentation and real-time presentation, but still some documentation process is not completely random. There are still some items that are recorded in real time. But then what really became clear is that this digital pen is probably going to be just one of the tools that we could use to capture information from the environment. And here's the vision of that smart trauma bay from our perspective, that a little bit differs from the one that you saw in the big picture. But here we see basically some computer vision and RFID technology that RFID technology would potentially help with detecting medications and Foley bags and equipment that is being used, and we're already doing some experiments so we can detect when the patient is intubated, we can detect when the IV is being inserted, but then computer vision can also help with tracking patient positions, team members' position around the patient stretcher, so we can see if somebody's bent above the patient's head and holds a laryngoscope. Well, that's the intubation going on, right? So some of these could potentially be used to capture information from the environment if we're putting it onto that display. But this is more like on a long-term goal, and we are working towards it. Now, probably one of the questions that you've been asking, and I'm slowly approaching the end of my talk, is do they have time for technology use, right? I mean, who's going to interact with technology? These people are busy, hands and eyes, busy with patient care. And to answer some of these questions, but not all, we did a quick study of Workload to see who is working the most, who is working the hardest, who possibly cannot be given yet another task or at least another gadget or something to work on, right, in addition to patient care. So what we did through 65 resuscitations, we assessed the workload for four team members: nurse recorder, surgical team leader, ED physician, and physician evaluator. And we administered NASA-TLX survey, which has been used in aviation to assess workload of pilots. So we basically asked them how mentally demanding was this specific trauma activation, how physically demanding was this trauma activation, how hurried or rushed was the pace of the trauma activation, how successful were you in accomplishing what you were asked to do, how hard did you have to work to accomplish the level of your performance, and how insecure, discouraged, irritated, distressed, and annoyed were you during the specific trauma team activations. So what we found is that they all work hard, right? So they are all pretty overloaded, but the person who is really most worked out in this particular, in trauma resuscitation, is the person who is examining the patient. It's either a nurse practitioner or a junior resident who goes through those ATLS steps and examines the patient and report findings to the team leader. So that's the person who is always hands and eyes busy with the patient care and could never potentially be considered for either using or some information technology. And then when we looked at the factors that are affecting the workload, we saw that the more severe the injury is, the higher the workload. And then when we look at the mechanism, the penetrating trauma, we're again inducing more stress on team member and higher workload. And then also injury severity score, if it was higher than 15, it was also recording higher workload. And then the role was the resident evaluator or nurse practitioner. So what I really gave you here is just a little bit of flavor of the things that I've been doing and what ideas and directions in which we are going with the information technology to potentially improve some of the processes in trauma resuscitation. But along this process, there are really these three important challenges and considerations that we have to constantly keep in mind and think about as we study and develop these ideas. So first of all, we have to really look at what are the practical limitations of these new technologies. And just these experiments, initial evaluations of the digital pen prototype show that, right? I mean, we initially thought, oh, that would be a wonderful idea. Nurses already writing everything on the paper. Why don't we just use her as a proxy? Well, not really, because, right, they not document everything in real time. They don't necessarily record everything. Maybe they skip some information. Maybe they don't hear some information. So even though it was a great idea and potentially feasible, there are still some limitations that we have to take into account in that particular case. And then another important question is that we have to constantly keep in mind is, does the added benefit justify the expense? And we know how much is expensive and how much resources it takes to introduce new technology in a highly stressful, dynamic medical domain, but generally in medicine. If we don't see that these technologies are improving or helping patient outcomes and improving team efficiency, we don't really have that justification, right, to introduce such technology. And then finally, will practitioners adopt these technologies? So they really have to be super unobtrusive, super error proof, right? So they have to really work seamlessly, unobtrusively, and simply never fail if we really want them to be used in such dynamic and safe critical settings. And those are really huge challenges. Those are really big challenges that we are facing. So with this, I would like to sort of end my talk and just in summary tell you that, so despite the structured format of ATLS, we are still observing errors in basically all phases of trauma resuscitation. And then design IT support for trauma resuscitation requires this better understanding of team processes, and that's really what my mission is and what I've been working on all these years. And we really have all this cool technology out there. And it's getting cooler and cooler every day, right? But yes, we can apply some of that. We can work with some of those technologies, but we really have to think about how it's going to impact the work of people that we want them to use, and if it's going to have an effect on the patient outcome. So with that, this is just a team that's been working with us and with me from from Children's National Medical Center, from Robert Wood Johnson, from Rutgers, and this research has been funded by National Science Foundation so far. And we're hoping some more funding will come along. So thank you so much for your questions. I will just leave it, for attention. I will leave it here in summary, so if you have any questions, I'll be happy to answer.